Hello, everyone, and thank you all for attending today's webinar and joining us for the lymphedema webinar hosted by the WHS Education Committee. And please note, if you have any questions throughout this evening's presentation, please utilize the question and answers box, and we will address as many questions as possible at the end of the webinar. As a reminder, this webinar is being recorded. Our moderator today is Dr. Letitia Graves, and will be moderating this session. And our speakers, Dr. Rummana Aslam and Dr. Elizabeth Garfield.
My name is Elizabeth, lymphedema therapist.
And to you, Elizabeth, go ahead. I know that you have connections problem, but go ahead.
Okay. My name is Elizabeth Garfield. I'm a physical therapist and a certified lymphedema therapist. I've been practicing physical therapy for 20 years. I graduated from LSU Medical Center, School of Allied Health in New Orleans, Louisiana in 1996. I completed the lymphedema program at Monarch LLC in Blacksburg, Virginia in 2014. I am an employee at Fox Rehabilitation. I treat older adults in their homes in Northern Virginia.
So I'll go next. Or Letitia, you want to introduce?
Yeah, I think Letitia will introduce herself, and then you can continue. Yes.
Yeah.
Okay.
Okay, good evening. I'm Dr. Letitia Graves Dixon, and I will be moderating this evening's presentation. And I will turn it over to Rummana.
Thank you. So hello, everybody. Thanks for joining. I'm Rummana Aslam. I am a wound specialist for a very long time, but also board certified in physical medicine and rehab, and currently the chief of physical medicine and rehab at Yale University School of Medicine. So I think what we'll do is we'll dive right in for the sake of time. All right, so today our topic is lymphedema. As you all know, this is a very, very big topic. We are going to focus on acquired lymphedema of the lower extremity, which will exclude cancer-related lymphedema. So this is lymphedema that we commonly see in our wound centers, sometimes with ulcers, sometimes without, but this is what we are going to focus on today. This is going to cover just basic information on diagnosis and management. I know there must be some experts in the field in the audience, and I apologize if it is too simple for you, but we should give you a chance to add to our education when we do the Q&A question and answers. So I'll start with a typical patient that this is one of my patients. I'm sure you all see these patients in the wound center. When I saw the patient for the first time, he had this circumferential ulcer on a very swollen leg and a very VP leg for about 6 years, but nobody had addressed or treated the underlying lymphedema. This is a 50-year-old gentleman, obese, diabetic, with a very swollen, leaky leg and a chronic ulcer. And I will finish his story at the end of my presentation. So quick anatomy of the lymphatic system. Lymphatic system is connected with the venous and the arterial system. It's all one circulatory system. But what the lymphatics do is they collect the tissue fluid. They join larger vessels. Then the fluid goes through lymph nodes. These are stations where the lymph is filtered. And then the filtered lymph then goes through bigger channels. The biggest channels are the right lymphatic duct and on the right side, and the thoracic duct on the left, which then join the venous circulation. So all that fluid is then taken back to the venous circulation. Primary lymphedema is inherited. This is because there is some defect in the lymphatic vessels or the lymph nodes or both, and this is inherited. It is rare. What is very common is what we call secondary lymphedema, which is because of other causes that damage the lymphatic system. This is also a typical presentation that you see in your clinics. This is usually the stage we see the patients. And lymphedema, the physiology is basically, we say, both Liz and I, all edema is lymphedema. So anybody you see with edema has lymphedema. It is because of impaired lymphatic transport. What happens is there is progressive accumulation of lymphatic fluid, which is protein-rich fluid within the interstitial and fibroadipose tissues. This triggers chronic inflammation, and this is very important to understand. It is an inflammatory condition. And this chronic congestion of lymphatic fluid can itself induce adipose tissue growth and inflammation, creating a self-perpetuating cycle. The diagnosis, what we are going to focus for today, is basically clinical. History, there are risk factors and comorbidities that Liz will talk about, which you should address in the history. The physical exam, and we should do some basic underlying diagnostic tests to see the venous circulation as well as the arterial circulation. So the history will focus on factors that have affected the limb itself. And remember, we are talking about lower extremity lymphedema today. So anything that affects the limb, and then systemic factors. I will turn it over to Liz to talk about these factors and comorbidities.
So venous insufficiency contributes to lymphedema. This includes incompetent valves, post-thrombotic syndrome, and vein stripping. So it is crucial to be aware of venous disease and how it relates to lymphedema. It is important to refer patients to vein clinics to prevent the progression of the disease. Trauma to the skin, subcutaneous tissue, and bones can also cause lymphedema. Trauma includes surgery, fractures, burns, wounds, scars, recurrent cellulitis, chronic skin disorders, and inflammation. It is crucial to be aware of the correlation between trauma to the integumentary system and the bones and lymphedema. Teach patients and care partners to monitor the patient's legs for lymphedema and infection. Use guidelines
I don't think we can hear her, so I can continue. Everything got frozen here. Somehow I cannot advance my. Oh, you're back, Liz? Continue.
I'm back. Okay.
Yeah.
Mobility is crucial for managing lymphedema. Encourage weight loss and nutrition. Encourage walking and exercising while wearing compression garments. Refer patients to physical therapy and community mobility programs. Refer patients with Parkinson's disease to evidence-based programs, including LSVT Big and Rocksteady. Congestive heart failure can cause lymphedema. Diuretics used to treat CHF also exacerbate lymphedema because they rid the body of water but leave the solid waste particles behind. These solid waste particles increase the risk of infection and also attract more fluid into the limbs. Patients with CHF should be monitored for lymphedema. They should wear compression garments preventatively or in the early stages of the disease. Compression is not contraindicated for patients with chronic stable CHF. Nighttime habits are also important. It's important to ask your patients where they are sleeping at night. Do not assume that they are sleeping in their beds. Patients with CHF and lymphedema often will sleep in their recliners because they are managing their shortness of breath. They are not able to lie completely supine, and their legs are so swollen and heavy that they are not able to get their legs into bed at night. So when they're sleeping in a recliner, the hip flexion will kink off or pinch off access to the inguinal lymph nodes and therefore blocking the lymphatic flow. So it's important to educate patients, try to get them to consider sleeping in a hospital bed, maybe referring them to physical therapy to work on bed mobility, or maybe even teaching them to use leg lifters. As the patients start wearing compression and their limbs get smaller, they often will have an easier time getting their legs in bed and can start sleeping properly in bed. All right, Rummana, back to you.
Thank you. That was great, Liz. I am having some trouble advancing the slides. I'll try.
There we go.
Okay, physical exam. These are stages of lymphedema. This is examination of the lower extremity. So you can start with a stage 0. 0, you don't see any edema on the leg, but the patient will complain that the leg feels heavy or they may experience pain. This is an early sign where you can monitor the patient for development of lymphedema and start compression. Stage 1 is where you have swelling, however, it is intermittent and it will resolve with leg elevation. When patients wake up in the morning, they'll tell you that their leg is fine. As the day goes by, the leg swells up. Stage 2 is when the swelling does not resolve with a leg elevation. And the rest of the stages, as you see in the picture, the stage 2 and 3 are more commonly seen. That's when you get indurated skin. You cannot do pitting in the edema. You get these elephantiasis or big folds. And stage 4 is the most extreme with increased elephantiasis. Okay, let's see. There are some tests that we do regularly in clinic to diagnose lymphedema. These tests are positive because the skin in lymphedema is thickened. Lymphedema is inflammatory, so the lymph fluid stimulates keratinocytes as well as collagen, and it increases the layer thickness of the skin as well as fibrosis. So when you pinch the skin at the base of the second toe, this is called a stemmer test. If you can lift the skin, chances are there is no lymphedema, although it cannot entirely exclude lymphedema. However, if you cannot lift and pinch that skin and your fingers just roll over the skin, that is very indicative of having underlying lymphedema. The other test is also with pinching of the skin. It can be done at other parts of the body, called the bow tie test, where in one maneuver you gently pinch, roll, and twist the skin between the thumb and pointer finger. If you can do that, chances are there is no underlying lymphedema. If you cannot do that, as seen in the other picture, there is definitely lymphedema under the skin. I apologize for this technical issues. Did I miss? Okay, imaging modalities. I have listed some modalities here, but these are basically supportive tools in planning for lymphatic surgery, lymphedema surgery. These are not commonly used. It is a clinical diagnosis, and honestly, I've never used them. I diagnose it clinically and manage it. So management is usually you have to involve other specialists because of the comorbidities that need to be addressed, specifically congestive heart failure, venous insufficiency. The treatment for venous insufficiency related edema is the same as lymphedema. Diabetes, although not directly causing lymphedema, needs to be addressed because of the dry skin and the oozing skin. There is definitely risk of infection. I think there was, okay. So the management is intensive phase where it is uncontrolled lymphedema. And once you control it, and if they have associated wounds and they have healed, then you have to go to the maintenance phase. So the intensive phase has these components, and all these components are combined and called complete decongestive therapy, or CDT. Starts with aggressive skincare, manual lymph drainage, compression, which is the cornerstone of the treatment, and exercise. Sorry, here we go. All right. Skincare is very, very important because when there is dry skin, as seen in lymphedema, and you see in the first picture, I'd like to mention that you see chronic erythema as well. And this is mostly inflammatory, although clinical judgment needs to be used when there is infection, but this is very common that there is chronic erythema. The skin can be dry skin layers, and sometimes it is so hyperkeratotic. You see in the middle picture, these very thickened plaques of dry skin. These need to be cleaned. Meticulous washing of the skin should be done with a pH balanced soap and water. These dry skin can be softened with emollients. After softening, you can actually sometimes do sharp debridement, but all the skin needs to come off. Then you can also see sometimes oozing of droplets of fluid from different parts of the skin of the leg. Sometimes the whole leg is what the patient say, my leg is crying. So this is lymphorrhea, or leakage of lymph fluid from the skin. Again, it is high risk for infection. This needs to be treated, and there are different ways to treat it. Compression can treat it, however, it ends up getting the bandages wet. What I have found helpful is to treat topically for 1 to 2 weeks with a steroid and antifungal cream combination, and that takes care of the lymphorrhea, and then you can start your compression. Manual lymph drainage is a specialized massage, and this is a skill with trained clinicians and therapists. This massage is used to drive the stuck lymphatic fluid, which is stuck under the in the subcutaneous tissues, and kind of mobilize it to area of congestion, to an area of a functional lymphatic system. This is very important because if you put compression bandages, it's important that there is mobilizing, the fluid is already mobilizing, and the compression bandages then help mobilize the fluid even further. So the compression, it is very important to know that we go with stiffness of the bandage. And the bandages that we prefer are short stretch that are in the middle. On the other side is a zinc paste, which you see in Unabut, that has no elasticity. And that usually is not very practical to use in limbs which have a lot of skin folds and massive edema. It has no stretch. It can feel very tight and very uncomfortable for patients. On the other hand is the ACE bandage, which is the long stretch or very elastic. And again, it does not give you that desired stiffness. You have to wrap it really tightly if you need the stiffness, and it again is uncomfortable. The short stretch bandage is 100% cotton. It stretches for a few inches and does not stretch anymore. So by layering this, you don't have to apply it very tightly. You layer it in several layers, and that creates just enough stiffness, which creates a massaging effect on the leg. So I will talk about how we do compression bandaging. There are YouTube videos. You can learn it from a skilled therapist. Toe wrapping is something I wanted to point out in this picture. When there are edematous toes, you do need to wrap them. You don't wrap the little toe because usually doesn't get lymphedema and you can injure the little toe. So you wrap the first 4 toes, but you don't wrap them individually. You anchor the bandage around the forefoot, and then you go loop around each toe and then bring the bandage back and loop it around the forefoot and then go to the next toe. That's how it does not create that tourniquet effect on the toes. So these bandages are available in different widths and lengths. The widths are 4 centimeters, 6, 8, 10, 12, and the lengths are 5 to 10 meters. And these help in contouring to the different parts of the leg. So you start with moisturizing the leg. It's very important to clean the skin, of course, first, and then moisturize. Then you put a stockinette on the leg to protect the skin. Then you have to use a cast padding. This is a cotton roll. These are not compression yet. You wrap the cotton roll, and this is important because you can fill in the narrow parts of the leg. You pad the leg in a way that the contour of the leg or the circumference is almost like not even, but it doesn't have any valleys or narrow parts, because if you don't fluff them up, as we say, you can create a tourniquet or pressure point in that area. Then you start with the less width bandage around the forefoot because it's easy to contour that. Then you go to the next width, which is probably 6 centimeters or 8, depending on the size. You wrap it around the ankle and the heel. Then you go to the next one, which is 8 or 10 centimeter wide. You start overlapping and wrapping the lower part of the leg, and then you wrap more bandages, 10 centimeters or 12 centimeters width, to increase the layers. Sometimes we use 3 layers, sometimes 5. I've even seen 7 layers, sometimes in very uncontrolled lymphedema, very big legs. So it should look very nice. I always say that compression is in your hands and not in the bandage. This first picture shows that when you start bandaging, especially around the foot and the foot has to be held at 90 degrees angle with the leg. So you tell the patient to point your toes to your nose, because you don't want to create any pressure points in front of the ankle. You can put extra padding there. And this is the position we stand and walk. So this has to be bandaged with the foot in this position. You can also put pads behind the knee when you're going, including the knee and the thigh. The other thing to know is this bandage is sustained compression. So the bandage stays on. Depends on drainage and leakage. If there are wounds that are leaking, of course, you treat the wounds with absorptive dressings and other treatments, then apply these bandages over that. But if there is drainage, then you have to change it more often. However, if there's no drainage, you do it twice a week, 3 times, even sometimes once a week, but they stay on. And because of the nature of the material, these bandages don't stretch. They actually maintain their position and the layering. The compression has to be safe. So I will say that patients need to be educated. They need to be educated on reporting signs of overcompression if that happens, if their feet start getting numb or they are experiencing any pain or any friction anywhere. It needs to be applied again and the skin needs to be checked. We always want to see what the arterial circulation is in that limb. Usually with patients with this massive lymphedema, there is very little chance that there is critical limb ischemia. However, you do need to know, and sometimes we use this test more often. We're very practical to measure the ankle brachial index and the pressure volume recordings by placing blood pressure cuffs on different arteries on the legs. And that report gives you a value of ankle brachial index, ABI, which is a calculation based on blood pressure, and also gives you the blood pressure at the ankle. So if normal ABIs are 0.8 and around that area, if there is ABI less than 0.5 or ankle pressure less than 60 millimeters mercury, then you should not use sustained compression. This patient needs to see a vascular surgeon, get their limbs, improve the vascularization, arterial circulation, to be specific, and then you can decide on the compression. But they can have intermittent compression or other methods of pneumatic compression, which I'll talk about. Exercise is hugely important. I have yet to see a patient who comes to me and says for the first time when I see them that I have been walking and exercising. They tell me very proudly that they've been sitting all day with their leg elevated because that's what they were told. But that is wrong. I tell them if you have to sit for some reason, like reading or watching TV, for more than half an hour, keep your leg elevated. But I want you to walk if you're able to walk. If you're not able to walk, you do these ankle exercises to move your calf muscles, because venous blood flow, which of course, is related to lymphedema. If there's venous insufficiency, it leads to lymphedema. So venous blood flow is anti-gravity. The effect of gravity is that it tends to pool the blood in our veins in our near our ankle and foot. But what happens, how does it flow anti-gravity to the heart? It's because the muscular compression of the veins, negative intrathoracic pressure, and the main pump, I tell people, for venous circulation, the heart is in the calf. The calf muscle will pump the blood up. These first two pictures are from a paper. I have the reference below. Dr. Hugo Parsh, who was the world authority on compression. Basically, rather than going into detail, what it does show is that he measured compression pressures under compression bandages. On the top is the short stretch bandage. On the bottom is compression stocking. And what he shows, the pressure of the effect of gravity that tries to pool the blood is 80 millimeters mercury. So when you're wearing your compression bandage, which is a short stretch bandage, and you do dorsiflexion, move your ankle, or you walk, you actually you have a counter pressure of 80 millimeters mercury, which will help with your venous circulation. When you stand, it's about 70, and when you're lying flat, there is very little pressure, maybe 30 to 40. As compared to the top picture on the bottom, with compression stockings, if you do dorsiflexion or you walk, the elevation of pressure is not that much. So basically what it's telling us is that if you walk with compression bandages, which are short stretch compression, that is the best anti-gravity force that compression can get, and also has a very good massaging effect on your circulation. So I tell patients if they have exercise equipment at home or they can go to a gym with the compression bandages, I want them to do a treadmill or at least walk at home. And as I said, if they are chair bound, they can do ankle exercises. After the leg circumference is better controlled, the skin is better, wounds are healed, the patients need to be educated that this happened because there was a damage to the lymphatics. Those lymphatics are still damaged. So the root cause of the problem has not gone away. We have treated it, but we have not cured it. So this has to be maintained, and you need to continue to see the patients. And one size doesn't fit all. So there are many options. Some patients are very compliant with compression stockings, and that's good if they can put them on and wear them regularly. They have to be changed every 6 months. In addition to that, if they cannot wear compression stockings, there are Velcro style compression garments that they can wear. Sometimes patients have learned how to do compression bandaging with short stretch bandages. These can be washed and reused, or the family can do them. And sometimes when they get recurrent edema, they just wrap their legs at home and they keep the wrapping on for a couple of days. And then once the edema is down, they can go back to their regular compression garments. All of these compression stockings, garments, and the bandaging can be combined with what we call a pneumatic compression pump, that picture on the top, where you see these long inflated sleeves on the legs attached to a machine. That causes this massaging pressure on the legs and improves venous return and decreases edema. This should be used for an hour at least twice a day, or at the least once a day, but just for an hour. It can be applied over the compression bandages. Exercise, again, is the key. That has to be compression and exercise has to be maintained for life. A little bit I wanted to talk about obesity and lymphedema, because there is a link between lymphatic vessels and lipids, and link between obesity and lymphedema. This is from a paper, I have the reference here, where you see that there are adipose tissue cells and the dermis on top with lymphatic vessels. Lymphatic vessels are in very close proximity to the subcutaneous adipose tissue layer. This is a result of a mouse study where lymphatic leakage from the vessels was shown to increase the adipose tissue mass with both individual cells hypertrophy as well as proliferation of the cells. So they increased in mass and also multiplied. And what happens is this is a vicious cycle. So why is that? There is inflammatory signals from the lymphatic fluid, which are adipogenic signals, and they then drive this increase in adipose tissue. Once the adipose tissue increases, it compresses the lymphatic vessels, and that increases the lymphatic dysfunction, and so it is a perpetual cycle. I think Liz did mention that it is important to know, especially in patients with congestive heart failure, that it is, I just wanted to bring this point again because it is important that it is well managed. Because what will happen is if it's not well managed, then you drive several liters of fluid from the leg back into the circulation with compression bandages. It happens over a few days, of course. However, that increased fluid can overwhelm a heart if it's not pumping well, and the patients can get pulmonary edema. So you want to make sure and work with their cardiologist that they are controlled. And the diuretics we'll again mention, if they are used, this is important, if they are being used solely for reduction of swelling in patients with lymphedema, then it is contraindicated because they will increase the concentration of proteins and macromolecules in the lymphatic fluid, make it more thicker and viscous. That increases the inflammation and leads to changes in the skin. However, if they're using diuretics for CHF, then you have to balance that, and very important to work with the cardiologist. Surgical management, I've listed some of the surgical procedures. They are good procedures, but they are used in very selected patients, not in our day-to-day management. Our management remains conservative for the most part. These management are either to restore anastomosis between lymphatics and veins or for debulking. I have used plastic surgeons for debulking when patients have such a big mass of lymphedema, stuck tissue, basically in their thighs, so their mobility is affected. But we will not go into the details for the sake of time today. Getting back to my patient and finishing the story here. So this patient, when I saw him for the first time, was treated with wound care, very aggressive, good wound care, for 6 years, had ended up in the ICU with sepsis many times, was obese, over 400 pounds, and diabetic, and with liters of fluid leaking from his legs every day and very bad malodor. So what I did was I kept the same treatment for the wounds. That wasn't changed. It's basically antiseptic treatment, cleaning the wound, absorptive dressings, but I started doing compression bandaging. I also encouraged him to lose weight. He refused to have bariatric surgery, but he did start losing weight and lost about 100 pounds in a few months. I sent him for PT to do exercises on the treadmill and other exercises. The compression bandages initially were done every other day because of they were getting wet, but when they stopped, when the drainage became better, then it was 3 times a week and then twice a week. The second picture is after 12 days. It shows all that slough and the yellow tissue, everything resolved. I didn't even have to debride anything, just with good compression, and you see new skin islands showing through the wound bed. And this was progressive over the next few months. More and more skin started forming on this wound. Compression was continued. And in about 4 months, there was very little wound left, and he was completely healed in 6 months. Very compliant patient, and the main treatment was compression bandaging, skin hygiene, exercise, and weight loss. So now I'll turn it to Liz because we wanted to have a little spin-off and discuss something totally novel today, just to pique everybody's interest. Back to you, Liz.
All right. So chronic pelvic pressure ulcers are a huge problem for patients with spinal cord injuries. These wounds are on the greater trochanter, the sacrum, and the ischial tuberosities. Many patients have had wounds for many years. They have endured, they have endured multiple trips to wound clinics and hospitals. They have had surgeries and multiple courses of antibiotics, often without success. Fluid in and around the wounds containing microorganisms prevent wound healing and create infections that often spread to the bone. So today I will present a plan using the components of complete decongestive therapy to decrease the edema for this patient population, to decrease bioburden, increase oxygen, and facilitate wound healing. Okay, so I'm going to go through a few slides, and then I will incorporate how we can use these slides, use the information in a clinical scenario. So Rummana, if you could show the first slide.
I don't know what happens, but here we go.
Okay. So this slide shows all of the lymph nodes that are present in the abdomen and in the pelvic area. So these lymph nodes are like your pumping stations. When they pump, they draw fluid, they draw lymphatic fluid toward them that they then filter and move on through the lymphatic channels. So these lymph nodes are accessed best through diaphragmatic breathing. Okay, go ahead and show the next slide. So these are the lymph nodes that are in the inguinal areas. So 1 and 2, the lymph nodes on the left are in the superficial lymphatic system, and number 3 shows the deep lymphatics. Okay, next slide. So here, this shows an MLD pathway. If you had pressure ulcers in the pelvis, you could do MLD from decongesting the buttock, decongesting the hip, stretching the skin toward the inguinal lymph nodes to decrease the lymphedema in these areas and promote wound healing. And the next slide. Upward from the buttock and the hip, going up the thoracic spine, up the lumbar spine, going toward the axillary lymph nodes under the armpit. So these are just creative ways to use rerouting techniques to really get the fluid out of those pressure ulcers, out of the buttock area, out of the lateral hip area. Again, using both the inguinal lymph nodes and the axillary lymph nodes to decongest that whole region. Okay.
All right.
The next slide is the infrared, a handheld. Okay. So here, this is the handheld infrared thermometer that I bought online. So I'm able to monitor the temperature of the involved leg. Like if you had a wound on the greater trochanter, you could monitor the temperature of that greater trochanter. Then you could compare it to the greater trochanter on the uninvolved leg. So monitoring temperature is a great tool. If the wound is full of bacteria, if it is very inflamed, the wound could be very hot. It could be a couple of 3 to 5 degrees hotter than the uninvolved hip. If the wound does not have a lot of bacteria, but maybe it's full of fluid, it's just a lot of edema. There's not a lot of fresh blood flow to the wound. The area is very hypoxic, low oxygen. So this lack of blood flow to the area could cause that wound to be cooler than the uninvolved side. So again, this tool allows you to monitor the wound, comparing it to the uninvolved hip and showing how the temperature should be calibrating as you perform complete decongestive therapy and promoting wound healing, so that the temperature of the wounded side should become similar to the hip on the uninvolved side. So exercise. We know that exercise is a vital component of complete decongestive therapy. So how can we help patients with spinal cord injuries, quote unquote, exercise when they may have a complete or partial spinal cord injury? So literally, exercise is technically a muscle contraction. So you could use neuromuscular electrical stimulation, putting electrodes laterally on the peri-wound area around the wound, turning the machine on, increasing stimulation so that you facilitate a good, effective muscle contraction. So this is a very effective way to exercise, facilitating muscle contraction of the glutes or the gluteus medius or the gluteus maximus, getting muscle contraction, which will also help to decongest those wounds. Also, components of CDT is compression. Patients who have pelvic ulcers could wear biker shorts or some sort of compression undergarments to help decongest the pelvic region. Skin care is also important. If the patient has a lot of exudate, hopefully they're able to have absorptive dressings. But let's say maybe they don't, maybe they are lacking caregiver support, maybe they've had wounds for a long time. The wounds could be draining into the peri-wound area, causing maceration, causing damage to the peri-wound area. Or the patient may also be incontinent, which causes a lot of damage to the skin. So barrier ointments are important to protect the skin from wound exudate and incontinence. Also, moisturizing the skin is important. I recommend using creams instead of lotions. Creams have a higher oil content. They will prevent moisture from the skin from evaporating and preventing moisture from evaporating and drying out the skin. So a cream has a nice oil ratio that will prevent evaporation. Lotions have a higher water content and will not prevent evaporation, and they can actually cause more dryness.
So Liz, we have to give time for questions, so we should wrap it up. Yeah.
Okay. So also avoiding creams with perfumes that can cause allergic reactions. Okay, so that's it. So let it be open for questions.
We'll open up for questions, but before we do that, I would like to make a note that the Wound Healing Society or the Education Committee, we don't endorse any of the presented products. It's for demonstrative purposes only. There are many brands of these products. Thank you for your attention. Thank you, Liz, for being my co-presenter, and we'll open for questions now.
Thank you both so much for that presentation. We do have some questions in the Q&A, and if you have additional questions, please feel free to drop those in the Q&A box. So our very first question is, how do you manage papillomatosis?
Yes. Yes. So, yes, papillomatosis are these nodules that you see in very thickened skin, and they are basically fluid-filled nodules. So you get something called lymph pads. They are soft material with sort of bubbles on them of foam. They are different size of these bubbles, and you can put that pad directly over the skin under the compression bandages, and they will push those nodules, they will push that fluid out of the nodules and flatten them.
Thank you. Um, Next question. So you all were talking a little bit about spinal cord injury toward the end here. How do you avoid AD or autonomic dysreflexia if using surface stimulation to elicit muscle contractions in persons with SCI?
Well, again, you could just monitor their blood pressure, monitor their symptoms, and just see. Again, if the patient has a lot of issues with that, again, you don't have to use functional electrical stimulation. You could skip that. You could use just the MLD with compression and the skin care. So I was just trying to give a way to show electrical stimulation, some way for these patients to exercise. If the patient is able to actively do hip external rotation, hip abduction, or hip extension, that would be appropriate too. So
Or
again, you could
passive exercise, range of motion
yes,
by a therapist.
yes.
Hopefully that answered your question.
Yeah, say great. So we do have another question. Can you speak to diosmin hesperidin use or MPFF for lymphedema, VLU, and lymphedema use?
That's a great question. I don't know if anybody in the audience or Muhammad has an answer because I have not personally used that. So I'm sorry. I may have to research that a little bit but I'm sorry, I haven't used that.
Okay.
If somebody can add to it, maybe.
Yeah. So yeah, if the person who asked that question maybe want to expand a little bit more, we can go back and revisit that question. I know I had a question.
Mhm.
You were talking about obesity and lymphedema, and I wanted to know if you can speak to lymphedema versus lipidemia, like how those are different
Yeah.
and how they overlap.
Yeah, so lipedema is not very well understood, but it is basically not a lymphatic disorder. It is a sort of abnormal fatty or fat tissue hypertrophy, and it can affect any areas of the body. And it is basic accumulation of fatty tissue. Um, some of these patients may not have any lymphatic dysfunction at all. But the legs, when you look at the legs, they are swollen, but there is one sign that the feet are spared. And if it is in the upper extremity, the hands are spared. So the cutoff is really at the ankle. You'll see the feet are totally normal, and the ankle is oftentimes normal as well. But the fatty distribution, the causes are related to some hormonal disturbances in females. It is mostly seen in females. Sometimes it is linked with hypermobility, so that needs to be seen if that patient has hypermobility. But there is not much treatment except that the compression and the other treatments that we do for lymphedema, like exercise, compression, and sometimes even MLD, because fatty tissue will trap lymphatics and may cause some element of lymphedema as well. So MLD, compression, exercise, these are indicated for treatment. So the treatment is about the same. This is a very disabling condition because a lot of times trying to lose weight does not really help. So I think it's just lifestyle compression, keeping the weight, at a reasonable weight goal, working with obesity medical specialists. But it is important to recognize lipedema versus lymphedema, and that's where some of these advanced imaging modalities can help to rule out any dysfunction in the lymphatics. That way, we know that it is basically abnormality in the fatty tissue.
Okay, thank you. Thank you for that. I that the from the previous question, that participant was able to follow up and said 10 randomized control trials done in Europe and in 2018 meta-analysis on VLUs. Um, and they would be happy to share data with you as that's something that they're using in their wound clinic.
Oh, I would love to share that data. So, Johanna, would you connect us, please?
Okay, and I think we have time for one or two more questions. So I had another question,
Mm-hmm.
kind of in the same vein of what we were just talking about with lymphedema, but how do patients often have misconceptions about what lymphedema is, and what would those be, and how do you kind of educate them?
Yeah, so the often patients, this is a very commonly misdiagnosed condition, and patients will go to general practitioners and be put on diuretics.
Mhm.
And as I said, patients are not educated why they have this problem, what's going on. So I think education is missing. And then they're asked to elevate their legs. So they do everything that we don't want them to do. They sit all day with their legs elevated. And they're told to wear compression stockings, and compression stockings cannot be worn by everybody. So there is non-compliant, they don't know what's going on. And so once you start educating them and to tell them why we are doing what we are doing, and that this condition is for life, this is not something that will go away, but it needs to be treated. And that is very helpful for the patients. I'm hoping that with this talk, and anybody is welcome to reach out to me just to educate the patients and recognize what we need to tell them. That was the
Um,
whole idea of this talk, basically, in a
Hmm.
nutshell. Liz, would you like to add to it, please?
yes. So I work primarily with older adults. Older adults will tell me things like, I restrict my fluid. I don't want to drink water because if I drink water, my legs will get more swollen. So then they will restrict fluid and they will become dehydrated. So I have to teach them that they need to continue to drink water. Um, they definitely think that diuretics, they're definitely prescribed diuretics more often. And then they say they're running to the bathroom all the time and their legs are still very swollen. So that's very frustrating to them, to tell them they should not be restricting fluid and they should not be taking diuretics if they're prescribed diuretics solely for lymphedema. They also will think that a TED hose, even a TED hose after surgery, which are anti-embolytic stockings that should be worn when you're bedbound, but TED hoses are not compression. Um, they will say, can't I just wear compression with zippers because they're easy to put on? Generally, if a patient has true clinical lymphedema, if they have weeping lymphedema, they need more than a zippered compression, which I think only has like 8 to 12 millimeters of mercury of compression. Um, they will pull out compression, they will pull out quote unquote compression garments. They will pull out just basic trouser socks, pantyhose, compression socks that are many years old that have holes in them. So again, educating them, and then they'll say, well, the compression isn't working. And it's because they're not wearing enough compression, their compression is too old. They need to be replacing the compression garments every 6 months. So yeah, those are the common misconceptions that I come across.
That's an excellent point about the our aged patients, I'll say, especially the dehydration, because they definitely need more hydration.
Mhm.
So I'll say we do have another question. Um, are there any courses that you recommend to learn manual lymphatic drainage massage, and they are based in the US?
I think Liz can answer that.
Well, I mean, you can become MLD certified in and of itself, where you're just doing learning the manual component. Um, so you don't have to learn how to be full CDT certified, which involves compression. So you can get MLD certified. Again, I went to Monarch LLC with Carmen Recuprio, and I believe now they're offering even more stuff virtually. So I definitely recommend considering getting MLD certified. There's lots of great ways to use it in practice. So, especially if you want to get more involved with treating chronic wounds, chronic pressure ulcers, they're all so swollen. The MLD is wonderful skill. Also, if you want to teach your patients something, you can even just start with skin sweeps. Even if you don't know how to do MLD, just put your hand directly on the skin, sweep it toward the lymph nodes, letting your hand glide along the skin as you stretch the skin toward the lymph nodes. You are stretching the skin, creating a negative effect. So you can just start practicing with skin sweeps.
So thank you. Thank you. So that concludes our Q&A. We are right up the top of our hour, or getting ready to hit the top of our hour. Thank you to all the participants who had questions. Thank you again to our panelists, and I'll turn it over to you,
Thank you very
Mohammed.
much, Letitia, for the moderating this webinar, and also for our wonderful speakers. The very informative webinar today, very practical. And I would like to thank you all for attending our lymphedema webinar brought to you by the WHS Education Committee and Wound Healing EU. As a reminder, this recording will be available in your member-only account on the Wound Healing EU and on the WHS YouTube in the next few weeks. Thank you all and have a wonderful day. Thank you.